Welcome to the AUA News Inside Tract podcast. Today's Inside Tract podcast is part of the Voices series, which is brought to you by the Diversity, Equity, and Inclusion Committee. Here we'll be joined in conversation with committee members, AUA members, and urologists from around the world to discuss how to build a strong, vibrant, and diverse urological community.
Well, hello, I'm Dr. Amanda North. I am the chair of the AUA Data Committee, which produces the annual AUA Census every year, as well as data from the AUA Registry. I'm also the chief of pediatric urology at Montefiore Medical Center in the beautiful Bronx. It is a pleasure today to be on this podcast with Dr. Kevin Koo, who is also on the Data Committee and is the chair-elect of the AUA Legislative Affairs Committee. He is a beloved friend and colleague all the way from the Mayo Clinic. And Kevin, if you want to introduce yourself.
Nice to see you, Dr. North, and thanks for having me today on this podcast to talk about something that's very important to both of us, which is the results of the AUA Census and the release of the 2023 AUA Census data report. I'm an endourologist at Mayo Clinic in Rochester, Minnesota, and I have the pleasure and distinction of serving as the next Legislative Affairs Committee chair for the AUA. And in that role, I'm excited to be able to highlight alongside you some of the findings from the 2023 AUA Census, in particular those that have connection and relevance to the advocacy work that the AUA does on behalf of our community and our patients. So thanks for having me today, and look forward to highlighting these very interesting findings with our community.
So that brings up a really good point. Everyone may not know, this is the 10th anniversary of the AUA Census, which is pretty exciting for those of us who have been working on this project over many years. But one of the goals of the AUA Census is to help support the legislative agenda of the AUA. And I think some of the data we found on this year's census, or last year's census really, that was just published this year, is very relevant to some of the work you do on the Legislative Affairs Committee. I'm wondering if maybe we could even start by talking about some of the issues with prior authorization and the data we found on the census this year.
Absolutely. I think that as the census has grown over the past decade, we've recognized how valuable these data that are collected can be, not only in informing the practice of urology and taking a snapshot of how we practice, how our colleagues practice, and where the gaps in and needs are in our profession, but also the connections that we can make with other work that our community does. And as you mentioned, the Legislative Affairs Committee and the Public Policy Council at large really can build on the data collected from the census to understand how we can best serve our members and what improvements we need to advocate for with our members of Congress and on Capitol Hill and in state legislatures across the country. One of the most beneficial aspects of now being able to look at longitudinal data over the past 10 years from the census is that we can see how practice patterns and practice barriers have changed. And we'll dive right into some of the highlights from the 2023 census on insurance and access to care. As you mentioned, prior authorization has long been an area that urologists have identified as a challenge to their practices. Prior authorization is when insurance carriers require patients and practices to submit documentation or otherwise justify potential services that have been requested or ordered by the urologist. And according to our community from the 2023 census, more than half of practicing urologists believe that their clinical outcomes are moderately or severely affected by treatments that require prior authorization. That's about 54% of urologists. And over a third believe that they're extremely affected. And part of that is because almost half of practicing urologists report submitting more than 10 prior authorizations on behalf of their patients in a typical week. So when our colleagues believe there's a certain procedure that's needed or treatment that they've ordered, insurance carriers are stopping them and are requiring additional information, additional documentation, sometimes requiring peer-to-peer conference calls to justify the need for those authorizations. And what we know is that while sometimes the prior authorizations can help to ensure cost-efficient and good use of healthcare resources, often these prior authorizations lead to unnecessary delays in care, undue burden on practices, urologists, and patients. And we're seeing it in the data here with our colleagues saying that more than 10 times a week, they're needing to stop what they're doing. They're needing to devote their resources, the resources of their office staff, to trying to get over these hurdles. And so this is contemporary data, and this is something that we from the public policy and advocacy side will need to continue to work on to try to reduce these barriers.
Well, it's interesting that you bring that up too, because although we didn't formally do an assessment of burnout on this particular census, we did ask practicing urologists if they experienced burnout or stress related to work. And 70+% of urologists said that they were experiencing burnout or stress. But when we stratified by gender, over 85% of women urologists were experiencing burnout or stress related to work, and almost 70% of men. So, this prior authorization burden is likely contributing to this burnout and stress that we're seeing. And that's really concerning for the future of our workforce, I think.
I agree. We know that professional burnout comes from many different sources, and it may be different for different people. But one of the most important contributors to burnout is the loss of control, the loss of autonomy. And all of us who practice urology do so because we care so much about our patients, and we've trained for many years and devote a lot of our lives and our careers to doing so. So the feeling that an insurance carrier or a peer-to-peer conversation with somebody who's not a urological professional, right, to have those conversations over and over again, to take time away from taking care of patients, that's no doubt a contributor to feeling like we're not able to practice urology the way we know how, the way that our patients deserve to have urology practiced with them. So certainly something we need to keep an eye on, and information that will be useful to our public policy team as we continue to advocate for reducing these unnecessary delays in care due to prior authorization. What are some additional highlights that you found interesting from this census?
Well, I think for me, following the demographic trends of urology over the last 10 years has been really interesting. And I'll give you one example is we've seen the percentage of women in urology increase. In our first census, we had 7.7% of practicing urologists were women, and we're now up to 11.8%. But one thing that concerned me is it feels like, looking at the trend lines, that the percentage of women in urology is not increasing as quickly as I expected. Now, some of that may be, we know that 25% of urologists under the age of 45 are women, and only 1.2% over the age of 65 are women. So when some of those older urologists start to retire, we may see that jump that we were expecting to see this year. But I am concerned that that trend seems to be flattening. By the same token, when we look at other demographic groups, for example, there's been a lot of work to try to increase the percentage of Black urologists. And we're just not seeing the data to support that that's working. It's been pretty stable around 2% from 2014 until today. And I'm hoping all of the work with mentorship that's been going on, and I know that our DEI committee has been really hard at work at mentoring medical students from underrepresented backgrounds. And I'm hoping that we will see a change in the percentage of Black urologists in the future based on that mentorship. But I am concerned that we haven't seen it yet. Do you have any thoughts on that?
Well, both of us work in academic centers and training programs, so we have a front row seat to seeing what the pipeline looks like. But we both know from our work that training a urologist takes a long time. And although we're now looking at 10 years worth of census data, the time it takes to recruit and mentor young, potentially interested undergraduates and medical students through that training process, hopefully recruiting them and retaining them in urology training programs, and then eventually releasing them to the workforce to practice in the communities that need them. That's a 10 plus year process. And so those efforts, the result of those important efforts that the AUA and other specialty society partners are doing now, we hope to see the rewards and the fruits of those efforts soon. But the 2023 census may not yet capture some of the results of that work. But it's important for us to keep an eye on it because we need to know what's happening with our workforce and what's happening with our pipeline. Some of the earlier workforce studies on women in urology projected that because the percentage of women graduating from training programs was steadily rising, that we would see a concomitant linear rise in women entering the workforce into practice. I think this data shows from the 2023 census that although the number of women does continue to rise, that it may not necessarily continue to be in a linear fashion, and that we have to be cautious of and adjust for some of those expectations where we may start to see a leveling off of the rise, or some of our colleagues may be deciding to drop down to part-time work or to practice in other ways that we may not fully account for. So the annual census is a way for us to keep tabs on those workforce trends and understand what the real world impact of these programs and initiatives to strengthen our training pipeline and our practice workforce may be.
Yeah, I think that's a good point. I mean, I think when we think about women in urology and also workforce issues, we know that we have a problem with lack of rural urology. But when we look at women in urology, they're far more likely to be fellowship trained than men. They're more likely to work in academic medicine or in other forms of employed urology, which may make it harder to recruit the women to rural areas. And I know you and I have both done a lot of studies looking at the importance of increasing our rural workforce. And it's interesting how the changing demographics of the urologic workforce as a whole may actually worsen that rural urology problem. Do you have any thoughts on that?
I think we both understand, our community understands how vital it is that the urology workforce represents the community across the country that we serve, right? We say often that urology is not just a men's health issue. It's not just a women's health issue. It's not an older patient issue. Our conditions cover the entire breadth of the lifespan. And so because urological issues and concerns affect all patients of all ages in all types of communities, we need to make sure our workforce is prepared and is distributed in a fair, equitable way to help patients wherever they may work and live. And so understanding those workforce trends, but also those demographic trends is going to be so vital to helping us know where the gaps in access may be. And as you mentioned, the rural workforce and making sure our rural patients have adequate access to safe urological care continues to be a priority for the census and for the AUA. So the fact that some of these trend lines have not changed dramatically, for instance, the fact that only about 62% of counties continue to have no practicing urologists, that's something that we've worked on for the last 10 years when those percentages first came up. And it takes a lot of multifaceted interventions and solutions to move that needle. So still more work to do to ensure that we're serving our patients wherever they need us.
Well, and speaking of challenges to the workforce, I thought some of the ergonomic data that came up in the 2023 census was pretty worrisome, especially when we look at women practicing urology. I mean, you know, none of us want to have to stop being surgeons because we have pain from doing surgery, right? But when we looked at the data from the 2023 census, 16% of women were complaining of musculoskeletal problems and 12% of men. I mean, that's really scary. I mean, that's a lot of people who are having musculoskeletal complaints. And, you know, I think as we look at the mid-career people having even more musculoskeletal complaints, when we look at workforce, the mid-career urologists are sort of the like workhorses of our workforce, right? We know they tend to work the longest hours and see the most patients. And so when we start to see that urologist population having musculoskeletal complaints, having pain from doing surgery, that made me a little bit worried. I don't know about you.
Absolutely. And the data on ergonomics, I think, is one of the highlights of the 2023 census report because we captured data about ergonomics and ergonomic injury due to professional responsibilities that we haven't seen before. And so this is novel data and certainly interesting and exciting to those of us who care about the workforce and care about workforce longevity. It's not just about training enough urologists, but it's ensuring that we have a sustainable workforce, a healthy workforce that can continue to serve patients for as long as they wish to. So the most common types of ergonomic injuries being reported by our community are those musculoskeletal injuries, often attributable to performing laparoscopic or robotic surgeries. And that was interesting to me. And although that's not unique to our surgical specialty, because non-urological surgeons have also reported this, the fact that laparoscopic and robotic surgeries are one of the touted benefits is that they're intended to improve positioning, improve the ergonomic strain on surgeons. So the fact that so many of our colleagues are reporting MSK type injuries while they're performing these types of procedures really does raise concern. And so I think it not only shines a light on increasing attention to these types of injuries and helping our community devote appropriate resources to education, training, and helping each other become aware of our ergonomic positioning. But I think it's also something we need to pay attention to because these types of injuries, if they really are occurring as frequently as 1 in 8, 1 in 7 urologists, then that can be a real burden to taking people even temporarily out of the surgical workforce. And we know we can't afford to do that. Our patients need us and they need us to be as healthy as we can to perform their procedures and provide the best care they can get.
Yeah, I agree. And I'm going to take a little moment to do a personal plug, which is we have a burnout course at the annual meeting. And 2 years ago, we added Chris Krauser from Michigan to our course. She does a unit on ergonomics. And it's funny because I now make my OR team do stretches in between OR cases. And some of those stretches come from your institution for the Mayo Clinic and are available online if people want to look at some ways to improve their ergonomics in the operating room. I think there's some pretty interesting work out there, and maybe we just need to do a better job of getting the message out. I think improving our ergonomics in the OR is something we can all do a little bit better, and definitely something I've become more aware of over the last few years. I'm hoping that the census data will encourage other people to pay more attention, especially earlier in your career, right? I mean, I've been in practice 17 years, so if I've been doing it wrong for this whole time, I'm probably going to be suffering already. But for people who are just starting or still in training, there's an opportunity to learn how to do it better from the beginning and try to avoid some of these problems.
Exactly. These are healthy habits that we need to build and become aware of, but then we need to sustain, just like any healthy habit. So fortunately, it's never too late to become aware of how we can optimize our surgical ergonomics and help to reduce the cumulative strain of these potential injuries.
Speaking of healthy habits, I was a little concerned that 1/3 of urologists said that they use maladaptive coping mechanisms to deal with stress and burnout. That's not such a good number either.
Yes, it really does shine a light on some of the things we're doing in a positive way, but then some of the things that we do need to pay more attention to and remind each other and ourselves how we can sustain those healthy habits to respond to professional burnout or other stressors at work.
Yeah, 20% using alcohol to cope with, and I'm not against a drink every so often, but seeing that 20% of people are willing to admit that they use alcohol to cope with stress and burnout, I don't know. I think we can need to do a better job in promoting healthy habits in our own specialty.
I think that's absolutely true. And never has it been more important for us to support ourselves and each other. Healthcare is difficult. Being a urologist, practicing with all the stressors that are in healthcare now, those are difficult things, and so we need to look out for ourselves and each other, and make sure that we're coping responsibly to the ups and downs of our careers. I wanted to also highlight some of the practice pattern specific data. And specifically, we asked our census respondents about how they treat stone disease, one of the most common conditions, and certainly one that dominates my practice as an endourologist. But each year on the census, we like to take a peek at some of the specialty-specific practice patterns that our colleagues have engaged in. And the endourology section of the census report highlights that 90% of practicing urologists report treating patients with stone disease. And that's not surprising to us, since stones are so common and such the foundation and bedrock of general urology. And then we dug a little deeper into how our colleagues are treating stones. And not surprisingly as well, holmium laser continues to be the workforce laser for laser lithotripsy, currently in use by most practicing urologists. And so although there have been new innovations in laser technology, including Moses holmium laser technology, as well as thulium fiber laser, at this point, over 70% of urologists are reporting non-Moses holmium lasers as their go-to laser. I suspect that those patterns may start to change as practices look into additional laser technologies, updating their lasers, and because the landscape of laser technology is changing so quickly now, I think we're going to see some changes when we ask these questions again a few years down the road. Another highlight from the stone disease section was how urologists choose to leave or not a drain at the end of stone procedures. And 82% of census respondents said that their preferred drainage option after uncomplicated ureteroscopy is the standard double J ureteral stent. And we have good data now to show that after uncomplicated ureteroscopy, drainage may be optional, and omitting a stent is a reasonable choice for selected patients. And while some of our colleagues are doing that, so over a quarter preferring the stentless drainage option, it looks like the double J stent still is the preferred option for many of our colleagues. And so we'll see now as the stentless option, or as leaving stents for a shorter amount of time, as those practice patterns start to permeate the practice landscape with some of our newer trainees or urologists who have been exposed to those options, we'll see what happens to these practice patterns, because I think everyone knows how the burden of stent-related symptoms and how bothersome and morbid those can be. So we'll be keeping an eye on endourological practice patterns and seeing how those may change in the upcoming census administrations.
Well, and I think it'll be interesting to see, as we delve more into the census data, if different practice types are more or less likely to leave a stent. Is your level of rurality related to whether or not you leave a stent, right? If you have a large catchment area and someone has a complication and you didn't leave a stent, are they going to have to travel 4 hours to come see you? As we dive into this data more, we'll have a better understanding of what could be some of the reasons people choose stentless versus stented ureteroscopy. I think that's part of the beauty of the census, is there's the opportunity to dive in deeper to the topics that are kind of interesting to each of us.
Absolutely. Now, if our listeners and our community members want to learn more and see some of the other highlights from the 2023 census, how can they do that? Where can they access this information, Dr. North?
Yeah, so any AUA member has free access to the census. The AUA census is published on the AUA website under the research tab. You can see all of the previous published censuses from 2014 up until 2023. Now, we've been talking about the practicing urologist census, but there is actually a census for residents and fellows. There is an advanced practice provider census. Also, there is an international census. The census also gets published by AUA section. We've done some census work on practice managers and even on medical students. So there is a lot of opportunity to understand different aspects of the urologic workforce. And I would be remiss if I didn't remind people that they can still fill out the 2024 census, which will be available through the end of the summer. And the data is more valuable the more people who fill out the survey. if you filled out the census before, a lot of your demographic data is auto-populated, and we really work hard on our committee to keep the census as short as possible while still asking as many relevant questions as we can, but we do try to respect people's time if they choose to fill out the census. So whether you are an APP, a resident, a fellow, or a practicing urologist, take a look at the AUA website to find your link to filling out the census. Do you have any final thoughts?
We want to encourage everybody, whether it's your first time taking it or you've taken it for many years, to please contribute to the AUA census so that you can be counted, your needs can be seen and heard, and we can direct our resources at the AUA and our specialty society partners to helping address some of the gaps that we've been talking about today. And so all it takes is a few minutes of your time, and our members can access the census at auanet.org/take census, all one word. Again, auanet.org/take census. Do it today, be heard, and be counted.
Thank you so much. It's been such a pleasure talking to you about a topic that I know we both like to nerd out about, but hopefully this will inspire some other people to take a look at the census results and think about what it means for the future of our specialty.
It's been a pleasure to join you. Thank you so much.
This has been Voices, an AUA News Inside Track podcast, and is brought to you by the Diversity, Equity, and Inclusion Committee. For more information about the AUA's diversity, equity, and inclusion efforts, visit auanet.org/diversity.